Pain affects every area of medicine, from acute care to chronic disease and end-of-life management. The Caribbean College of Family Physicians, Jamaica chapter, presents a two-part pain management webinar series. Part 1 will be hosted live via Zoom on Thursday, February 19, 2026, and Part 2 on Sunday, February 22, 2026. This series is designed for physicians and healthcare professionals seeking practical, evidence-based approaches to pain management. Part 1, which will be live Zoomed on February 19, 2026, beginning at 6:35 p.m. Jamaica time, focuses on the common and complex pain presentations seen in everyday clinical practice. Part 2, which will be live via Zoom on Sunday, February 22nd, starting at 2 p.m. Jamaica time, explores multidisciplinary and psychosocial aspects of pain, including safe and effective prescribing. Sessions are led by experienced consultants and moderated to ensure relevance to general practice. Each webinar carries 2 CME hours, with certificates issued upon verified attendance and completion. Registration and payment details will be on our flyers, which are in circulation with separate registration portals for each day. Join us for both days of this essential pain management webinar series. Thursday, February 19th, 2026 at 6:35 p.m. and on Sunday, February 22nd, 2026 at 2 p.m. Zoom links for each day can be accessed below or on our flyer.
Guardians of Caribbean Health, the vital role of family physicians. Across the sun-kissed islands of the Caribbean, family physicians stand as pillars of their communities. They are the trusted caregivers who know their patients by name, their histories, and their families. These dedicated professionals provide comprehensive medical care throughout their patients' lives. From the bustling streets to the tranquil shores of the Caribbean islands, family physicians are the first line of defense against illness. They treat a wide range of conditions, from common colds to chronic diseases. They are also instrumental in preventative care, promoting healthy lifestyles and early detection of potential problems. The importance of family physicians extends beyond their clinical skills. They are deeply embedded in their communities, understanding the unique cultural and social factors that influence health outcomes. This intimate knowledge allows them to provide care that is both effective and culturally sensitive. In a region facing challenges such as limited healthcare resources and rising rates of chronic diseases, the role of the family physician is more crucial than ever. Their dedication, compassion, and expertise are essential for building a healthier future for the Caribbean. A legacy of care. The Caribbean College of Family Physicians. For over 2 decades, the Caribbean College of Family Physicians, or CCFP, has been a driving force in advancing family medicine across the region. Established in 1987, CCFP is dedicated to improving the health of Caribbean people by promoting and maintaining high standards in general practice. The organization achieves this through education, advocacy, and fostering a strong network of family physicians. At the heart of CCFP's mission lies a commitment to people-centered, continuous care. This approach recognizes that healthcare extends beyond simply treating illness. It's about understanding the individual needs of each patient and providing holistic care throughout their lives. CCFP provides its members with valuable resources, including continuing medical education, professional development opportunities, and access to the latest research in family medicine. These resources equip physicians with the knowledge and skills they need to provide the highest quality care to their patients. Through its unwavering commitment to excellence in family medicine, CCFP plays a vital role in shaping a healthier future for the Caribbean. Its work empowers physicians to be effective leaders and advocates for the well-being of their communities. Global Impact, Regional Action, CCFP's partnership with WONCA. The Caribbean College of Family Physicians recognizes the importance of collaboration in addressing global health challenges. CCFP is a proud member of the World Organization of Family Doctors, or WONCA, a federation of 131 member organizations representing over 500,000 family doctors worldwide. This partnership with Wonka provides CCFP members with access to a global network of family medicine professionals, fostering the exchange of knowledge, best practices, and innovative healthcare solutions. It also allows CCFP to contribute to the development of international standards for family medicine education and practice. CCFP's commitment to regional action is evident in its active involvement in shaping health policy in the Caribbean. The organization has been instrumental in key health policy meetings, including the Nassau Declaration on Health and the Port of Spain Declaration. These declarations address critical health issues facing the region, such as non-communicable diseases and the social determinants of health. By actively engaging in regional and global health policy discussions, CCFP ensures that the voice of Caribbean family physicians is heard and that the unique healthcare needs of the region are considered. If you are a family physician committed to improving the health of the Caribbean people, we encourage you to join the Caribbean College of Family Physicians. CCFP membership offers numerous benefits, including continuing medical education, professional development opportunities to enhance your leadership skills, advocate for your patients, and contribute to the development of healthcare policies. Research and publications. Global connections. Join the Caribbean College of Family Physicians today, whether by direct membership, by chapter membership, and be part of a movement that is shaping a healthier future for the Caribbean. Together we can make a difference. Become a member and make a difference.
Good evening, everyone. Thank you so much for joining us for Pain Management Part 1. Practical approaches to pain management in general practice, addressing the common and the complex. Today is Thursday, February 19. We thank everyone for joining us today online as we look forward to a wonderful webinar. Our moderator today is Dr. Moina Spencer French. Dr. Spencer French holds a Bachelor of Medicine and Bachelor of Surgery MBBS from the University of the West Indies in Kingston, Jamaica, with several years of experience in palliative medicine. She has received comprehensive training in the management of malignant diseases. Her foray into palliative care commenced in 2015 at the Hope Institute. During her tenure at the Hope Institute, Dr. Spencer French achieved her Doctor of Medicine, DM, in Family Medicine from the University of the West Indies. In August 2025, she completed a fellowship in palliative medicine from the Institute of Palliative Medicine, where she focused on developing palliative care in low and middle income countries. Dr. Spencer French is a consultant in palliative medicine with a focus on community-based care in private settings. She provides nonprofit education services aimed at enhancing the quality of life for both malignant and non-malignant patients who face financial barriers to necessary palliative care. Additionally, she's a member of the International Association of Hospice and Palliative Care. Ladies and gentlemen, your moderator for today's session, Dr. Spencer French.
Hi, good evening, everyone. I'd like to thank everybody for joining our pain management webinar session tonight. At this present moment, we'll have the college prayer.
Grant me the opportunity to improve and extend my training, for there is no limit to knowledge. Help me to correct and supplement my educational deficiencies as the scope of science and the horizon widen each day. Give me the courage to recognize my daily mistakes, so that tomorrow I may see and understand more clearly what I could not comprehend in the dim light of yesterday. Bless me with a spirit of devotion and self-sacrifice, that I may treat and heal thy suffering servants, prevent disease, and preserve health to the best of my ability and knowledge. Grant that my patients may have confidence in me and in my art, and that they may follow my counsel and guidance. Grant that neither greed for gain, nor thirst for fame, nor vain ambition may interfere with my work. May I see in the afflicted and the suffering only a fellow human being in need. Amen.
Thank you for that prayer. I now invite Dr. Senna Ononojo, the president of the CCFP Jamaica chapter, to bring greetings and an overview of tonight's presentation.
Good evening, everyone, to our specially invited guests, Doctors Mark Minot, Francine Gill, Karen Phillips, and Kanchana Bandarako, distinguished colleagues, our sponsors, IT and technical support personnel, Mr. Samuel Heron of Oatgate Solutions Limited, CCFP Administrator, Mrs. Lynn Thompson Hyatt, friends, ladies and gentlemen, a pleasant good evening to you all. Pain is an unpleasant sensation which we all have experienced at one time or the other during our lives. It is a multi-dimensional experience. This evening, we will be examining the various dimensions of pain. Our primary focus today will be on musculoskeletal, headaches, neuropathic, cancer-related, and end-of-life pain. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. It is a subjective personal experience influenced by biological, psychological, and social factors acting as a protective warning signal. Consequently, there are different aspects of pain and different types of pain. Today, we are going to explore some of the practical approaches to pain management in general practice while addressing the common and the complex. The Caribbean College of Family Physicians has set various mandates. Among them is the enhancement of knowledge and skills of doctors throughout the region via the use of various media as well as collaboration with other organizations. This evening, we are pleased to explore pain in its various manifestations and management. As such, we have with us a cadre of knowledgeable and experienced speakers, Dr. Mark Minot, consultant orthopedic surgeon, Dr. Francine Gill, consultant neurologist, Dr. Karen Phillips, consultant endocrinologist and diabetologist, and Dr. Kanchana Bandarako, general practitioner with special interest in palliative care. Thanks to the planning committee of the Caribbean College of Family Physicians Jamaican chapter for inviting them to share their time, knowledge, experience, and expertise with us. I am confident that we will be well informed and enriched by their presentations and subsequent discussions. Doctors Mark Minot, Francine Gill, Karen Phillips, and Kanchana Bandarako, a wholehearted welcome to you all. A special welcome to our members and all other attendees who continue to support us. On behalf of the college, I welcome you all, invite you to sit back and enjoy the presentations. Thank you, and as always, God's richest blessings.
Hi, sorry about that. So our first presenter, Dr. Mark Minot, unfortunately is unwell and he will not be able to join us today. So our next presenter is Dr. Bandara Kaur, and she will be presenting on cancer-related and end-of-life pain. So Dr. Bandara Kaur Dr. Bandara Kaur earned her MBBS from the University of the West Indies in 1995. Since 2004, she has practiced as a general practitioner at Manuchant Medical Center with a focus on home-based care in Kingston and St. Andrew, starting in 2020. Between 2025 and 2018, she received training in basic palliative care through workshops organized by the Jamaica Cancer Care and Research Institute, the Hope Institute, and the Massachusetts General Hospital. Additionally, she completed online fellowships in palliative care and compassionate spaces through the Institute of Palliative Medicine and St. Christopher's Hospice. Dr. Bandara Kaur is an active member of the Caribbean Palliative Care Echo Group, which convenes monthly to discuss complex cases with fellow physicians. She is deeply committed to palliative care, geriatrics, and mental health, and strives to raise awareness about the importance of palliative care in today's healthcare landscape. Thank you, Dr. Kaur. You can go ahead.
All right, thank you. Let's see if I can get my slides up. Right. And let's get us to slideshow. Okay. Everybody
Perfect.
see my slides?
Yes, perfect.
All right, great. Okay, so I had not originally intended, I didn't expect to be the first speaker, and I had kind of assumed that some of the stuff that could potentially have been included in this presentation, I kind of left out because I figured other people would be talking about it. And Dr. Onanujo actually did give a little bit of introduction, so I think I'm still safe. My topic was a practical approach to managing cancer-related and end-of-life pain in general practice. I kind of reworded the topic a little bit to incorporate the fact that it's a practical approach and it's for general practice, which is essentially what I do. So let's see if I can leave you guys with some practical knowledge. All right, so in talking about pain management, I felt that it was important to differentiate between nociception, pain, and suffering. And I would define nociception as nervous system signals that are triggered by tissue damage. So it's essentially a physical situation. Pain, on the other hand, is something that is more of a perceptual experience, and it is kind of unique to the individual and involves an interplay of physical, psychological, spiritual, and social dimensions of what it means to be a human being. And what that means is that pain is what the person who feels it says it is, right? I quote the "he who feels it knows it." I like to define suffering as the result of ruptured relationships. And I define it as ruptured relationships because I use the word relationships in the context of interdependencies, to highlight the fact that we don't and our bodies don't operate as an isolated cell, organ, or system. And we don't operate as an isolated individual. We operate in a context of other people. And so all of those dimensions come into play and are related to each other. And when those relationships are disrupted, it challenges our capacity to cope. And pain is one of the experiences of suffering. And this is the one that we are going to be looking at today. Now, if we think of suffering as ruptured relationships, we can think of palliative care then as a response to that suffering that is aimed at identifying, restoring, repairing, or replacing these damaged relationships. And we all know the WHO definition of health, but I prefer to think of health as a capacity to adapt and restore. Because if you're just only talking about well-being and life is full of change, when well-being changes, when something changes, then that means all of a sudden you're not healthy. So I think the health is actually more about our capacity to adapt and restore balance when we're faced with change that causes disruption. And when you take it in that context and we talk about healing, we can think of healing then as the restoration of balance. And this is possible. That restoration of the balance of those interdependencies within you is possible even when a disease or illness cannot be cured. And that's really what palliative care is about, restoring balance even when disease or illness cannot be cured. And even when it can be cured sometimes too. So relationships, I spoke about relationships, and I think what I want to start with is that a very key relationship in managing cancer care, cancer pain and end-of-life care is the relationship between you as a physician and your patient. And this relationship is a vital element in the provision of care. And as a family doctor, it's a relationship that is often nurtured over time. And I don't think we always recognize the value that it carries in addressing the suffering and promoting healing. So it's something that we need to recognize, that the relationship you have with your patient is that first point of interaction and the first opportunity for healing. In managing end-of-life and cancer-related pain, the first principle then is to be fully present and actively engage with your patient on all parts of their journey, but especially this potentially final part of their journey as a human being. So when we are assessing for pain, I am going to go into some general principles. And again, this is one of those places where me now going first when I had not intended to has a little bit of an impact. But I don't think I need to go over with all of you the way that we are supposed to assess pain, the way that we were taught as students and have continued to practice as physicians. So you ask about the site and the onset and the duration and the frequency and all of those things. So those are all the physical components of the pain, and we need to be thorough and document all of that. Not because we know there's a cancer there doesn't mean that we don't actually treat each pain in each symptom in its entirety. Ideally get the information from the patient. But apart from those usual questions that address the physical dimensions, it's important also to consider how the other dimensions of being human are impacted or are impacting the experience of pain. So questions like, what do you think is causing the pain? What is it? Is the pain limiting what you want to do? And if so, how is it limiting what you want to do? What are your fears about pain? What are your expectations of the treatment? And what is important to you as we work on managing this pain? These are not questions that we necessarily would think to ask, but they are questions that highlight the fact that pain is more than just the physical experience of tissue damage or injury. So they're important to include in your history. And then when we're creating a care plan at end of life or for cancer pain that is due to a cancer that is not necessarily likely to be cured, what we also need to recognize is that the goals of care change when we're dealing with that end of life situation. And the change in the goals of care is essentially a shift from trying to improve the quantity of life to improving the quality of life. And it's important that we discuss the shift of goals in care with the patient and with their family so that they appreciate that we are not necessarily removing treatment or abandoning them or doing nothing, but that we are changing what we're going to pay attention to. And that's one of the first steps, in fact, in managing the pain of cancer at end of life. When the goal is comfort, every intervention that we consider must be weighed in terms of the benefit versus burden in the present moment, because we may not necessarily have years and years to wait for some potential benefit while the burden is being borne in the present moment. So an intervention that we're going to engage in must have more benefit than burden if we are going to opt to take it. If the burden is more, if the if the difficulties that the patient is going to have to endure are more than the benefits that they will gain from that intervention, that's an intervention to either discontinue or to not start in the first place. And because pain is something that is individual, and because the quality of life is also something that is very subjective, and it's dependent on what is important to the patient and to their family, it is important as we create that care plan to respect the priorities, the values, and the wishes of the patient as well as their family. And the other thing I want to put in here is that when you're creating that care plan, we should also avoid requesting tests and investigations that are not actually going to impact the management of the patient. So if, for example, you have a patient who is no longer able to get out of bed, and you suspect that they perhaps have had a pathological hip fracture, but we're not going to be necessarily doing anything active about it more than managing the pain, is it really necessary to do an x-ray, to put that patient through an x-ray? Because how is that going to change the way that we manage the patient? So these are the kinds of things that we want to think about as we're creating that care plan. So remember also that since our goal has shifted to relieve suffering and not defer death at all costs, we are now required to have an open and honest conversation with your patient about what death and dying means and what it is that the patient wants to have in the time that is left to them, what they want to do, what they want to take care of, and what they want to pay attention to. And each of us has to find our own way to have that conversation with the patient. I can share with you what I usually do, which is to emphasize the fact that the cancer or whatever illness it is that we cannot cure is actually only affecting the physical portion of the person, the body, the physical body, and the other portions of them, the parts of them that we may call the spirit or the soul or whatever it is that, however it is that you want to term it, the part that is not vulnerable to death and decay, that part is still intact, and that we can still address what is going on with that part and allow that part eventually to take its leave, because it is not intended to be here. The body is not intended to last forever. So the container, the body is a container that holds the spirit. And when it is time, the spirit has to leave that container. And what we are supposed to do as physicians is to help the patients to take that, to make that separation, leave the body behind and allow the spirit to go. And you find your own way to put it. You find your own words that will come with practice. But these are conversations that we need to be having so that we can then tailor how we are managing the pain to the needs of the patient. Okay. So what's going on here now? Slides seem to be stuck.
Try clicking on the slide.
So, yeah,
There you go.
I got it.
Yeah.
I got it. Okay, so I want to use a case and tell a story to show you how we put these principles into practice. So Claudia is a patient of mine. She's 83 years old, and she's a mom and a grandmom, and she was diagnosed with breast cancer. She was diagnosed with stage 4 breast cancer about 6 months before I met her, which was about 2 years ago. And she was referred to me for a little pain management and a little home follow-up by the oncologist, because she was not a suitable candidate for any further aggressive cancer-directed treatment. So the little pain management issue that she had was that she was having fairly severe pain in her right arm, which was where the mastectomy, it was on the right side that she had the mastectomy. And along with the pain, she was also having tingling, numbness, and cramps, and unable to use the hands. So she graded that pain as an 8 out of 10. And when I explored a little further with her, what I got from her is that because of this pain, she has been confined to her bed and her room. So you might wonder why, because the hand is not needed for moving around. But for Claudia, she also had arthritis in her knees, and she needed a walker in order to get around the house, which she used to be able to do very well. But in order to use a walker, she needs to be able to use her arm. And because of the pain, she can't use her arm. So now she's confined. Her world has contracted now to be her bed and her bedroom, and she's afraid even to go to the bathroom by herself, and she needs help because of the pain. And she's worried. She's worried because this breast cancer was diagnosed in 2018. She had the surgery and the chemotherapy and whatever, and she was declared cancer-free in 2019. And then all of a sudden in June 2024, she went to the doctor for hoarseness. And before you know it, we did some tests and recognized that there was cancer all over in her lungs. And her understanding of her illness was that, okay, she has cancer spread all over. Doctor has given up on her. And she's not afraid to die, she shared with me, but she's afraid that she, with this pain and with this distress, and we're not doing anything about the cancer, she won't be able to spend the time with her children and with her grandchildren doing the things that she enjoys. So as I had this conversation with her and listened to her story, you can see where the fears were coming in and where the gaps in the knowledge in terms and understanding of what her situation was and what the doctors would actually be able to do for her lay. And you also recognize that, you would not imagine that arm pain is going to cause all of these other problems, but because it is linked to her mobility, it actually created it impacted other areas of her life, right? It impacted her social dimensions and it impacted her spiritual dimensions as well. So in coming up with a care plan, the first thing I had to do with her was to explain to her that it's not that we are not treating her cancer, in fact, because again, we can use that container and spirit situation and the fact that a human being is more than just a physical body to kind of put a different spin on this, which is to say we are not treating the cancer with surgery, chemotherapy, and radiation, but we are treating the cancer by allowing you to live as full a life as possible, because we know now that your state of mind, your state of heart in terms of your emotional well-being, your spiritual wellness, how connected you feel to a greater power and to the people around you, and how good your social relationships are, all have an impact on your immune system, on inflammation, and on your capacity to keep that cancer under control for a few more years, to spend a little more time with her family. And when I put it to her that way, she agreed that, yes, she really wasn't interested in the chemotherapy and all of that, but she just felt like she was being ignored. So I got her on board, and then I pointed out to her that if we could get the pain under control, then perhaps we could get her moving. She could get to the kitchen to start cooking again, and she could enjoy meals with her family and so on. And so what ended up happening was that she actually agreed to take the Panadine. So what she had been prescribed for the pain was Panadine F, 2 tablets 3 times a day. She stopped taking it because it was causing her severe constipation and it was making her drowsy. So her solution was to take it once a day. And she also, I think, was not taking it because she didn't appreciate that the pain in the hand may or may not necessarily be directly related to the cancer spreading, because it could have just also been related to the lymphedema that she had in the hand. But she felt like this is not going to solve the problem, which is actually the cancer, and didn't appreciate that everything is related. So got her on board. She took the Panadine F 3 times a day. Initially, she although she agreed to 3 times a day, she took it twice a day. Immense impact on her pain. And then eventually we got her to taking it 3 times a day. That got rid of the pain. And having seen the results with the Panadine F, she agreed to try the gabapentin for the nerve pain, which was causing the tingling and the cramps and the numbness. So we got her on that as well. But all of that would not have been possible if we didn't initially understand what it was that was bothering her. And also, if we had not addressed her issue of constipation, because that is a known side effect of the mild opioid, the moderate opioid that she was being given. And it can be a reason for somebody not to comply with the medication. So eventually the plan that we came up with over time and how we adjusted and modified the plan allowed Miss Claudia last year, July, to be actually up and about. So she's moving around all over the house with her walker. And she had actually returned to her sewing business, and she was busy sewing christening dresses for somebody who had ordered 60 christening dresses, which apparently I didn't know this, but they're very technical to sew because they have all the frills and the fluffs and everything. So this is an example of, for me, I think it demonstrates that just writing a prescription, and that prescription, the Panadine F and the gabapentin, were appropriate for the kind of pain that she was having. But that was only addressed at the physical component of that pain, and it didn't take into consideration the bigger picture of the total suffering. And so until we addressed all of that, the prescription had no use for her because she was not going to take it, right? And so when we're dealing with cancer pain and we're dealing with end-of-life care or end-of-life pain management, we need to consider the whole person. It's not just the part of the body that is hurting or the part of the body that is damaged or inflamed or whatever. It's the entire person and all the relationships within and without of that person. So that kind of speaks to the holistic approach. And then in terms of speaking, so there are lots of things that I could have chosen to talk about in this, but I have 30 minutes and I'm trying my best to stick to the 30 minutes. So I opted to address the second part of my talk to the use of opioids and specifically morphine in general practice in dealing with patients with end-stage cancer or end-of-life pain, because I think this is something that a lot of us are not comfortable with, and it is not something that we need to be afraid of. So if you know what you're supposed to be doing, and if you are comfortable to reach out for help and guidance, which is what I did when I started off, Dr. Spence would get lots of calls from me to go through how to work out the dosage and upgrade the dosage and so on of the different, and what morphine to use. Hopefully more patients can have access to that kind of management. So we're going to talk a little bit about opioids in cancer pain. So generally, morphine is the opioid of first choice. It's not the only opioid there is. There's Panadine F that we use to treat Miss Claudia has codeine in it, which is also an opioid. Fentanyl is another opioid. Pethidine is also an opioid, but is not something that we normally use in general practice for pain management. So morphine is the opioid of first choice for moderate to severe cancer pain, and we preferably would like to give it orally. And in order to adequately manage the cancer pain, we need it. The morphine comes in different formulations. So you have immediate release, fast-acting formulations, and you have sustained release, long-acting formulations as well. And usually we need one of the fast and one of the slow. Another important principle to keep in mind, especially when we're using opioids, but this is true for any kind of chronic pain management, is that the opioids need to be given by the clock, which means on schedule. And the schedule is determined by the onset of action and the duration of action of the formulation you're using. So the idea is to get a level of morphine in the system that will suppress the pain to comfortable levels. And then because we know that the nature of cancer pain is such that it will break through that level at some point, and those breakthrough pains also have to be addressed, we give additional doses on a PRN basis that will help to keep the breakthrough pain under control as well. And that's the reason why we need two types of morphine. The other important thing to keep in mind is that constipation is a predictable and definitely going to happen side effect when you prescribe morphine. So Dr. Spence, if she was given this talk, she would say the same hand that writes, the same pen, the same doctor, the same hand that writes the prescription for the morphine must also write the prescription for the laxative. And there are a variety of laxatives that we can use. Dulcolax is a common one. Skilax is a common one. Skilax drops, and those are both prescription. But you can also use Senna. You can use milk of magnesia. I've used magnesium citrate or magnesium oxide, and I've also used molasses in a little bit of milk. And the laxatives need to be given alongside the opioids, not waiting for the constipation to start. So along with those general tips, I'm going to share some information that is specific for Jamaica if you are trying to prescribe opioids. So not all pharmacies in Jamaica dispense morphine specifically. And the pharmacies that dispense the morphine can only fill prescriptions when the DDA pharmacist is present. These are important things to keep in mind. So for your area in which you practice, you need to know which are the pharmacies that will actually dispense morphine and will have it in stock. And also if the DDA pharmacist is there on a particular schedule, you need to know about that as well. So it's not a matter of just writing the prescription and sending it to the pharmacy. There are two types of morphine: mismorphine, which is a liquid fast-acting morphine, and fentanyl, which is a transdermal formulation of morphine. You put it on the skin, which currently, and this can change from time to time, which currently are only available through the public hospital pharmacies and through the University Hospital of the West Indies. And to fill those, you will need prescriptions that are written by doctors from the appropriate hospitals. So those of us who are general practitioners not affiliated with a hospital in private practice, we can't write prescriptions for mismorphine or fentanyl patches to be filled at these pharmacies. The other thing to keep in mind is that you need a paper prescription. It cannot be a WhatsApp or electronic prescription. And that paper prescription needs to have all the information that is required in order for the pharmacist to dispense the morphine. And that includes, because we don't always put all of this on a prescription, you need the name, address, and date of birth of the patient. You need, obviously, the prescribing instructions, the dispensing instructions for the morphine, the type of morphine that you want, the duration, and for how long you plan to prescribe that morphine. Also need your signature, your stamp, your medical council registration number, your address, and a contact number for you. And that contact number is important because if you leave anything off, the pharmacist ain't going to fill the prescription. And if they have a question about your dosing, they're not going to fill it until they talk to you and you can explain to them why you're prescribing what you're prescribing. And then if you're a patient, and these are the laws, right? So those of us who have any say, who have any links that they can use to get some of these things changed, I think these are things that we need to look at because they're not helpful. If the patient is unable to collect the prescription in person, and if you think about it, most patients with end-stage cancer at end of life are not in a state to go to the pharmacy and pick up their own prescription. You also need to provide a letter for the patient indicating that they're unable to pick up the prescription, and that letter has to go with an ID to a designated individual, a family member or caregiver or whoever who is going to collect the medication on the patient's behalf. So these are the ways in which the regulations are set so that people we don't run the risk of these controlled substances being abused. And when you do write that prescription, regardless of how long you write the prescription for, the pharmacist is only going to dispense 2 weeks supply. And there will be no refills until the date for the 2 weeks to be up is up. All important things to remember, because there are times when we have hurricanes and the hurricanes take a week to arrive and people's morphine prescriptions become due in the middle of a hurricane. And this actually happened to the patient that I'm going to talk to you about, who I'm going to use to demonstrate how we initiate and adjust treatment with the opioids, with morphine. So when we put these principles into practice now, I'm going to use my patient Kirk as an example. And he was actually a patient with throat cancer diagnosis. And when I met him, he had actually started on a course of chemotherapy at Hope Institute. But it was clear that what he had was metastatic disease. It wasn't localized. And I think he knew this as well. So initially, he had just moderate neck pain at the site of the tumor. And this was actually being managed reasonably well with Baralgin, but he had also been prescribed the mismorphine from Hope Institute to use if he needed, but he wasn't really needing the mismorphine at that time. As time progressed, so within about 2 to 3 weeks of my starting to manage him, he developed pain in the left hip and buttock. And we felt that this was probably due to some metastatic disease, perhaps in the bone or something. And that now required the morphine to manage. And it significantly impaired his mobility, significantly enough that he had to stop the visits to Hope Institute for chemo. So remember, he's on mismorphine, which is only available through the public hospital pharmacy. And that's what we started. So since he already had that at home, we started the treatment with that. But keep in mind that that's going to require a prescription from Hope. So I started him on, okay, what's going on here now? Right. So to deal with this hip pain, I started him on the dosage that was begun or that had been recommended by Hope Institute, the doctors at Hope Institute. And that's a reasonable starting dose for somebody who is otherwise okay. So it was 10 milligrams of the fast-acting morphine, that's the mismorphine, every 4 hours. And we looked to see how many doses he needed. And he was very reluctant to take it on schedule. So it took a few days for us to get a complete 24 hours to assess how much he actually needed. And it turns out that over 24 hours, he needed actually 6 doses to get reasonable pain relief. So when we calculate that now, 10 milligrams times 6 doses, that gives us 60 milligrams of morphine in total for the day. So we don't really want, because he's already giving trouble to take the 4-hourly morphine, we don't really want him to have to take a medication every 4 hours. And also we get smoother control if we can reduce the dose in frequency and have the medication that remains in the system for a little longer. So what we want to do now is, having initiated the treatment with the fast-acting morphine, now we want to convert him to what we call a sustained release morphine, which is given twice a day. So that total dose that we calculated as 60 milligrams, we're going to divide that by 2. So the dose of sustained release morphine that he's going to get twice a day would be 30 milligrams, right? And he can still take the 10 milligrams of fast-acting morphine every 4 hours as needed if he has breakthrough pain. And then once we've started him on this now, we need to monitor and see how many breakthrough doses he needs and whether the sustained release is actually managing to control his pain. If more than 3 doses of mismorphine generally, then that means that we need to increase the sustained release morphine dose. That's a twice-daily dosing morphine. So Kirk, our patient, ended up needing 4 doses of mismorphine every day to get through the breakthrough pain. So that adds up to 40 milligrams of mismorphine. So now our new total daily dose would be the total amount of mismorphine as well as the total amount of sustained release morphine. So 40 of the mist and 60 of the sustained release. That gives us 100 milligrams. So that's our new daily dose. And when you divide that by 2, you get 50 milligrams of the sustained release morphine to be given twice a day. And then the new breakthrough dose, because we've now increased the total amount, right? So the breakthrough dose is a portion of the total dose. You can either divide that total dose by 6, or you can take roughly 20%, about 20% of that dose. And for the maths here, the 20% was easier to do. So I gave him a breakthrough dose of 20 milligrams of mismorphine every 4 hours. And we managed with that, and eventually we increased the dosage as needed. And by the time he passed, he was actually at 150 milligrams of sustained release morphine twice a day. So it just goes to show that there is no ceiling dose when it comes to the morphine. Once you're going stepwise and you're being careful to assess what is happening, and you're systematic in how you increase the morphine, you try to titrate it. There is no maximum dose that you have to stop at. The maximum dose is only determined by how much the patient needs and how able they are to tolerate the side effects. Respiratory depression, although we kind of hear about it a lot before we actually get into the practice of prescribing it, is actually rare if the morphine is titrated very carefully as described and it's increased in a systematic way. I've never seen respiratory depression in the approximately 10 or 11 years that I've been learning to prescribe this. There is a phenomenon called morphine toxicity, which can present often as pain all over that is not responding to anything. And the treatment for this is to reduce the dosage, but this also is very, very rare. It will happen. The one situation where I actually saw it happen was actually a patient that I was managing who had come from the US on a variety of different kinds of morphine. And then he had other doctors who were also managing him who added other amounts, other different kinds of morphine. And all of these have different half-lives and different durations of action. And I think he ended up with too much morphine in his system because that essentially was what happened. But that's the only time that I've seen it. And it typically that is exactly what he complained of, that the pain that we were trying to treat was not responding. And in addition to that, he was now having pain all over. So the treatment was to reduce the dosages, to cut back on some of the morphine. So that essentially is where I'm going to stop, because I'm pretty sure I've probably gone over my 30 minutes now. There are a lot more things that we could discuss about the morphine. There is the way that you can so one of the things that happened with my patient Kirk was that he also had been prescribed a fentanyl patch from Hope. And the outpatient clinic at Hope was very helpful, because I wrote letters indicating that the patient was not able to come, and I was managing him, and we would appreciate if they could continue giving the prescriptions for the medication. They did up to a point, and then about a month before he passed, the doctor who saw my letter indicated that he couldn't prescribe any more morphine without seeing the patient, because it's been 3 months or 2 months since I'd seen him. So I now cannot get the patches, and we had to convert him to oral morphine, which can be done. And there's a process for doing that, but it's a little bit, I couldn't fit it into to all of what I needed to do. So maybe that will be for a part 2. But these are the kinds of challenges that we have, and these are the kinds of things that we can actually work through. And we have doctors who can walk us through it. And I suspect that when I was learning to do these things, I would call on Dr. Spence on a regular basis. I suspect that Dr. Spence is also, Dr. Spencer, I should say, Moina, is also equally accessible and available if you need help in learning how to dispense to prescribe the morphine. And it's one of those things that I think you need to just start, and you need to just learn how to do it and work your way up with the guidance until you are confident enough to prescribe it, because the impact of having that morphine is huge. And when you realize that it can make such a difference, and the thing that's holding us back from giving it is because we're afraid that we're going to have all of these other issues coming in, which actually don't happen if you know how to prescribe it properly. I think it's worth that in and of itself alone, perhaps, is a useful learning activity for general practitioners and family practitioners to be versed in the prescribing of morphine. That's all I have. I can stop now, and you can, if you guys have any questions or comments, I'm happy to take them if there's time.
Thank you, Dr. Bandar, for an excellent presentation. You also touched on the socio-demographic barriers that we face of patients within the community trying to access the various opioids. So right now, presently, I'm going to check the Q&A to see if there are any questions for you, and we can go through the questions, and then we will move along to a presentation by our sponsors.
Sure.
So the first question, I think you answered that already, which is what is the maximum dose you had to use, which you already answered. The maximum dose for Kirk was, I think, 150 milligrams
50,
slowly.
yeah, twice a day.
Twice a day. And the last question that I have in the Q&A, everybody, please feel free to add more questions. Do you use cannabis for pain management?
I have used, but I have not initiated the treatment on my own. I have co-managed patients with Dr. Spence, and she would have started somebody on it, or patients would come to me and say, okay, they want to try this. Is it okay to try? And then based on what they've wanted to try, I've done the research and asked the questions and said, okay, we can do it this way. I think there's a role for it, but I don't know that I am as comfortable with that as I am with prescribing the morphine, just because of lack of experience.
Thank you,
Okay,
Doc.
thank you for those.
Hey, Doc, if I could, so I have a few questions here that came in as well. They're not in the Q&A, if you'd allow me.
Sure.
So how do you navigate conversations with families who equate morphine use with giving up or imminent death?
We start essentially with that conversation about what death is, right? So before we get to, so as I said, before you start talking about prescribing medication and morphine and whatnot, there has to be a conversation about what the patient understands and what the family understands. And I think part of that conversation has to be about the fact that we all are going to die. And a lot of these patients are they're at end of life, whether that end of life may be months away or years away or days away. And so you have to pick up your courage and you have to find a way to have that conversation with the patients. When I first began having the conversations, it was hard. It was hard to initiate, but the patients are actually willing to talk. And if you present it in a way that is empowering, they don't feel like the morphine is giving up. Like my patient Claudia felt that the Panidine F was giving up because, that is an opioid, because she didn't see where that was helping with the cancer. But when she understood that there are other ways in which we can manage the cancer, not necessarily to cure it, but that you being free of pain actually is going to help the cancer to stay under control. And that's not something that is airy-fairy up there. There is actually research to show that when you improve the quality of life, you do actually improve the quantity of life. So it's never giving up. And you never say to a patient, there is nothing we can do. There's always something we can do. But what we do must be based on how much benefit we're going to get for how much stress it is going to put on your system. So that's kind of how I navigate it.
Okay, thank you. I see another question in the Q&A, Doc.
So this question is, what is the role of NSAIDs in pain control for terminal cancer?
So NSAIDs, as the name suggests, are anti-inflammatory, right? So if you suspect that there is an inflammatory component. So in fact, our patient Kirk actually he was also on, I forget which NSAID, but he was on an NSAID as well, because there were inflammatory issues in other parts of his body apart from the hip that were also causing pain. So inflammatory changes in the tumor in his neck, as well as he had a situation in his leg. And that was separate and apart from the pain in the hip. So there is a role for it, but I don't think the NSAIDs by themselves are enough to manage the end of life cancer pain, because a lot of the times that pain is not just inflammatory. There's other things going on.
So that carries me to this follow-up question. In cancer-related pain, how do you determine when to escalate from non-opioid or weak opioid therapy to strong opioids such as morphine?
So you get the patient to rate the pain, right? And you assess. So this was another slide that in retrospect, I probably should have put in. So the WHO has a ladder, a pain ladder, and you have mild pain, which you can treat with paracetamol or mild medications. You have moderate pain, for which you can use things like the Panadine and so on. And you have moderate to severe pain, and that usually moderate to severe pain requires opioids. And you determine moderate to severe based on what the patient tells you, because remember, that's what the patient is experiencing. And when you're assessing the pain at the first assessment, you ask them to rate the pain out of 10. So if they're giving a 2 out of 10, that's a mild pain. But if they're saying 8 out of 10, then it's time to move from, 3 days, 2 weeks down the line, you're getting an 8 out of 10. Then it's time to move on. And so that's one. The second thing is that sometimes from the illness, from the diagnosis of the patient, you can kind of have an expectation that certain things are not going to be needed. But again, my experience has taught me that that is not necessarily a 100% reliable way, because I have had patients who should have had much more pain and they did not need the opioids until the very, very last end. So I think the best way to determine if you're going to go from a codeine, like a lower mild opioids to the morphine, is when the patient tells you that the pain has escalated. So anything more than, I would say, like a 6, 7, anything more than 7 that requires opioids. That's when you escalate.
Thank you.
So another question in the chat is, what do we do when a patient is becoming addicted to the drug prescribed?
So it depends on what you mean by addicted. And I think that if morphine is prescribed, if it's prescribed and if it's prescribed properly and carefully and appropriately, it is unlikely that they're going to be addicted. They may become dependent on it in the sense that without the morphine, they're going to have severe pain. And then because their bodies have become accustomed to functioning with the morphine, they're going to have effects if you stop the morphine. They're going to have withdrawal effects if you stop the morphine, but I wouldn't necessarily call that addiction. And when you're dealing with end of life and late stage cancer pain, addiction is not really, the risk of addiction is less than the risk of the patient being in severe pain and suffering until they die, I think. Dr. Spencer, I don't know if you want to add anything to that, because you probably would have more experience as well in this, but that's generally my take on it, that I don't worry about addiction if we're dealing with end of life or late stage cancer patients, because I've not really seen it.
So I think with addiction is important to recognize that addiction is a psychological, has a psychological component. So when you are addicted to a substance, you spend all of the time chasing that substance and it interferes with your daily routine of life. Versus patients who have cancer, they do not want, they don't necessarily, they don't have a psychological component because the pain is so great. They just need the medication to alleviate the pain.
So that they can
So
continue to function
right.
in a
So there's
sense,
a
right? Yeah.
great difference between drug dependency where you have to, or tolerance to a drug where you have to keep increasing the drug because the person gets used to the drug and you have to go up on the medication in order to relieve their pain. That is not addiction. Another problem that we face is pseudo addiction, where doctors have not treated the pain adequately. And we see that a lot when you're trying to convert IM pethidine to oral pethidine. It's done incorrectly. So because it is done incorrectly, and we see this a lot in sickle cell patients, they keep presenting to the A&E with symptoms that seem to be addiction when it is not addiction, it is pseudo addiction. When you correct and prescribe the correct pain medication, then those behaviors will stop. So there is a great difference between drug tolerance, drug dependency, pseudo addiction, and addiction. With advanced cancer patients, they usually don't have a psychological component. They usually don't get addicted unless they have a previous history of addiction. And we can't get into that now, but there are tools that you have to apply to patients who have a history of drug addiction to see if, okay, is this person going to become addicted to the opioid that I'm prescribing? Do I have to co-manage him with a psychologist or a psychiatrist? So those are the various layers of addiction, but it is not usually seen in patients with advanced cancer. So we have 2 other questions, and then we're going to move on to our presentations or or sponsor presentations. So the last 2 questions are, what is the role of antidepressants in palliative care?
Wow. Okay. I'm not sure that I can answer that one off the top of my head. There is a role for them. It is reasonable to recognize that somebody is faced with a life-threatening, with a life-limiting illness, and they're having trouble coping with it, and maybe they have other unresolved issues, and there may be a need for medication to help, and the antidepressants can help there. I think the other situation so I've had patients who have been on antidepressants before the diagnosis of cancer, and we've maintained them on the antidepressants. But I don't know that I've necessarily had a lot of experience in terms of prescribing antidepressants, like initiating treatment with antidepressants for patients at end of life. So I may not be the right person to answer that question.
So my take on it, you have to apply the depression screen or depression tools, and depending on what is the score that you get, then you can say whether the person is depressed or not. But you have to understand that, as Dr. Bandara said, they're dealing with a life-limiting illness, a life-changing diagnosis. So naturally, they are going to have some form of depression, but it might not be to the extent of major depressive disorder requiring medication. It might just mean that they need some form of cognitive behavioral therapy or psychotherapy in order to cope with what is happening. So the last question, is there a place for tramadol in end-of-life pain management?
Yes, there is. I mean, we could also have managed it depends on the patient, and it depends on how severe the pain is. So there is a place. But tramadol falls into the step 2, level 2 pain. So I believe that's moderate pain. So if it's very severe pain, if it's like the pain that Kirk was having, the tramadol would not have been helpful there. There wouldn't have been a place for that.
Thank you very much, Dr. Bandara, for an excellent presentation. Now we'll have 3 sponsor presentations, very short presentations, and then we will move on to our other presentations of the evening. So our first sponsor presentation is from Indus Life Science. You can go ahead.
Go ahead, Mr. Dyer. We're
Is
seeing your
hearing me?
presentation.
Are you hearing me?
Yes, we are.
Oh, thank you very much. Greetings to everybody. Thanks for CCFP for this, for Indus to be on board today, and wish you all happy New Year 2026 as we're meeting first time in this new year. And Indus has always been part of the community. Even last year in October, after we all, went across this Melissa, we reached out many communities that was affected by Melissa, especially Black River, St. James, Trelawney's, as well as SAV, and we donate a lot of medication for those communities that are affected, and we still continue to do so. So with this, I just want to refresh some of the brands that we are being briefed to you regularly. Of course, this is for muscular pain, joint pain, back pain, shoulder pain, all those things. We have 2 medications. One is Capsitop. I'm pretty sure you're all aware of this brand. And the interesting is that this has a combination of 3 active drugs: capsaicin, diclofenac, methyl salicylate. The capsaicin is what I like to discuss. It's basically out of cayenne pepper, and how it helps to relieve pain is that it inhibits the triggering factor, the pain mediator substance P. So when substance P is inhibited, pain is depleted. Capsaicin effectively does the job, and it is approved by US FDA for nerve pain. And of course, we all know diclofenac, which basically inhibits prostaglandin. And the methyl salicylate is another pain inhibitor, which works on the other mediators like IL-1, IL-2, IL-6. So if you see the combination, it has three active drugs, works in three different pathways to deplete pain. It's a gel. So to be applied, at the area of pain. A little caution is recommended because of capsaicin is nothing but cayenne pepper extract. So not to rub aggressively, a gentle spread is sufficient. So this is a combination as you could see. And capsaicin has a lot of documentation, German studies, French studies. Of course, you could see in the screen, there's a US FDA label is also there for capsaicin. So it's very ideal for tropical pain. And of course, diclofenac, it's around 30-gram tube and it's over the counter, available in all the pharmacies across Caribbean. And obviously, it is recommended for all the pain, neck pain, back pain, joint pain, frozen shoulders, everything. And apart from Capsitop gel, we have a pain spray for quick onset of action. The highlighting point of this is, it is of course, Ready Spray is the brand. As you could see in the screen, the composition is very interesting. It's organic. There's no chemicals on it. Extract from plants, eucalyptus, turpentine, methyl salicylate, and menthol. So the spray, you all know, once you spray it, within seconds, the action kicks in. So that's a ready spray. It comes in two forms. 43 ml small container, which is roughly around $400 down here. And we have a bigger version, 150 ml, which is around $800 in the pharmacies. And again, ready spray, just like Capsitop, is also over the counter. Capsitop is a gel, Ready is a spray. So we have a nice tagline, just like KFC always keeps saying, finger licking good. We keep this tagline, powerful like a real beer, safe like a teddy bear. Why we say safe like a teddy bear? Because the ingredients all natural, no chemicals on it. So even children, if they got hurt, we can recommend this to spray. So that's already sprays over the counter. And the other brand, which I like to highlight because we have a couple of topics on diabetic neuropathic today. We have pregabalin, neurobalin, and I know most of the doctors do prescribe pregabalin, but I don't know how many of you really prescribe neurobalin. But doctor, today onwards, you can consider neurobalin because this is currently the most affordable pregabalin in Jamaica. Last year, I mean 2024, November, we dropped down the price. You could see in the screen, a pack of 30 pills of 75 milligram now cost $2,075. And under NHF, I'm pretty sure two indications definitely are there. One is diabetic neuropathic pain and epilepsy. NHF subsidizes 100% of the cost if it is prescribed as neurobalin. If you prescribe as pregabalin, sometimes they may give the expensive brand and still the patient end up paying more. But if it is neurobalin, 100% sure the cost is covered. And just as you could see in the screen, this particular patient has bought 30 pills of 150 milligram. The pharmacy markup, after markup, they billed it for 3,394 and the NHF subsidized 3,225 out of 3,394. So the patient ended up paying less than $150 for 30 days. So that's for 150. So 175 is fully subsidized. So that's on neurobalin. The last product which I just would like to run is an aminopep because it has B12 on it, which we all know is effective for no pain. It can be recommended. You could know the composition. I'm pretty sure all of you know about aminopep. When you talk about supplement, this is the most comprehensive supplement. There are many brands available. I'm not bashing them, but most of them offers only vitamins. Nothing can compare with terms of composition. Protein, vitamin, and mineral zinc is there with aminopep. This is a comprehensive formula to your patients. So any patient, for example, cancer patients can benefit of it. Sense of well-being. Amino acids helps really a lot as it has protein also. And I'm not just saying it is the best. You could see in the screen some brands that's available across Caribbean. Most of them offers vitamins. Aminopep stands tall, vitamin, protein, and zinc. That's what we did a lot of community with our aminopep. Last year, back to school, we distributed 3,000 school bags for school kids with all this. And this year, we are aiming to cross 5,000. So that's my presentation for the day. And thanks. Please enjoy the rest of the presentation. Have a nice day. Thank you.
Thank you very much. We'll now have the next presentation by Servicare Distributors Limited. You can go ahead, please. Thank you.
Hi, good night, everyone. Just checking to see if you can hear me clearly. Hello.
Yes, we can hear you. You can go ahead. We can also see your screen.
Okay, thank you so very much. All right, so my name is Oetan Clark, a medical representative from Servicare Distributors Limited. So I'm here to present the gathering with some options for pain management. So as I listen to Dr. Bandarapour's presentation, it's very clear that pain is one of the more pressing challenges that healthcare professionals have to encounter, right? And pain management is very important. When it comes to pain management, you need one, a quick onset of action, a long duration, right? So we have a variety of products that cover that gamut of features. We have our celecoxib, which is Aclexa. We have a combination product called Dorita, which is a combination of a mild opioid, tramadol, and the time-tested and proven analgesic paracetamol. We have a brand of pregabalin, which is Reusca, and we also have our flagship product. Those are my words. Naclofene Duo, which is our brand of diclofenac sodium. Excuse me. Now, a little bit about Kirka Pharmaceuticals. This is a generic pharmaceutical company based in Europe, and we are vertically integrated. Now, what this means is that we have total control over the quality of the products that we produce. So we manufacture all of the constituents of our medication. So we're talking about the capsules, the APIs, the excipients, everything is made at the same place. And it's checked at different phases in production to ensure quality. So what that means is that there's a significantly reduced likelihood of any contaminants like allergens or carcinogens that will be found in our products, which would eventually lead to a recall. Right? And you can check this in any AI, any search engine. No Kirka product has been recalled because of any contaminants found in the medication. Right? That's a verifiable fact. So as you can see here, our expertise leads to efficient and innovative solutions of high quality. Right? Now, excuse me, compliance, that's a big issue with pain management. And I mentioned earlier that we need to have quick onset and a long-lasting pain relief, right? We also want to minimize the side effects, and we also want to provide an economic solution for the patients. So the truth is, a medication can be groundbreaking, right? But the best intervention for a patient is the one that they take. And if something is priced out of reach of the patient, they won't take it, right? So Naclofene Duo is what I'm going to be focusing on for this evening. So this is a one-of-a-kind high technology production. We have a unique drug delivery system, and it's important that I highlight that no other NSAID on the market currently employs this type of drug release technology, right? Now, our diclofenac 75 is a capsule that has some pellets inside. Now, each capsule has 75 milligrams of diclofenac sodium. Of that 75 milligrams, 25 milligrams is quoted for immediate release. So this means that within 10 to 15 minutes, the patients begin to feel the analgesia from this, right? The other 50 milligrams is programmed for long-lasting release over 24 hours. And if you can look at the diagrams here, you can see the different layers that are constructed. So here we have an acid-resistant layer, and then neutral core for the quick release, and then for the long-lasting pain release, you can see the difference there. Now, it's important for me to highlight something. I think it's on the next slide. Okay? Now, what is very, very unique about our formulation is the fact that the pellets are gastric resistant, right? So no diclofenac at all is released into the stomach. So the stomach is spared, right? When you take the capsule breaks apart, but the pellets that contain the diclofenac, they are gastric resistant, right? They only begin to release in the intestines, not the stomach. And I'm stressing this for a reason, right? When the pellets eventually move from the stomach into the intestines now, they spread out homogeneously, as you can see in this diagram. right? Now, why is this important? Remember, one of the issues I want to address is, where is it? It is side effects, right? Now, all of us here would be aware that with treatment with diclofenac, there's always a risk of GI upset or irritation or injury that can be from some mild discomfort or pain to actual bleeding, right? Now, whenever I highlight the GI protective aspects of naclofen duo, the question invariably comes at me. So are you saying, Mr. Clark, that we don't need to use PPI with this product? And my answer invariably goes something like this. Your high-risk patients, your elderly patients, those who drink a lot, those who smoke a lot, um, those who have had GI issues in the past, right? Definitely still consider protecting them, right? However, for your otherwise relatively healthy patients, if you are going to use naclofen duo as a short course, like 5 to 7 days, once a person doesn't have any current issues or no history of GI upset, you may use naclofen duo by itself because we have protected the GI, we have protected the stomach because no diclofenac at all is released in the stomach, and in the intestines, it's spread out evenly. So imagine a hard tablet. Say this capsule was a hard tablet, right? There's always a risk of it sitting on one side of the stomach, and the concentration of diclofenac can cause some direct toxicity right here or right here. That's always a risk with the hard tablets. Or in the intestines, there's always a risk of it getting stuck in a groove somewhere right here. And that again can cause some direct toxicity, which would cause some localized irritation, right? But with the gastric resistant pellets, no diclofenac at all is released in the stomach. When it gets to the intestines, there's a just spreading out of the pellets. So there's no concentration of the diclofenac in any one place, right? So again, if you have a high-risk patient, the elderly patients, the persons who have had GI issues in the past, definitely consider protecting them. For your young, strong, healthy patients who just have some sports injuries or maybe a young lady having a bad period, you can try naclofen duo for up to 5 to 7 days without PPI, right? Now, it's also flexible in that one capsule is 75 milligrams. You'll notice here it says 1 to 2 times daily. This is at the physician's discretion. Yeah. So if someone is having a bad headache, you may not want to give them 2 capsules. One may be sufficient for them, right? However, if we're talking about a very bad period, post-operation, you remove that toenail or something like that, you want to give them 2 tablets. And I said it's flexible because this can be given OD or BD depending on the patient's presentation. So, as I said earlier, a headache, 1 tablet should be fine. You may give a start dose of 2 tablets, 2 capsules, sorry, at the same time. However, that's going to be it for the day. And you will do that in case you don't think that 25 milligrams of immediate release would be sufficient. If you think they will need 50 milligrams of immediate release, you can give them 2 at the same time, but that's it, right, for the day until tomorrow. Now, we spoke about economics earlier. So we give this to the pharmacies for 1980, right? And there's a it's essentially $21 NHF subsidy, right? So this works out to about $99 per capsule. And with the NHF coverage, 70 something, right? And there's always a possibility of using health cards to set off the remaining cost. Right? So remember, just a recap, no other NSAID on the market currently has this combination of quick and prolonged release plus GI protection, right? And I think this is a rough depiction of the pain management scale that Dr. Bandarakor was referencing earlier, right? So for your non-opioids, you'd want to use your Aclexa, which is your celecoxib, as well as your diclofenac, which is your naclofen duo. You may pair it with pregabalin, which is our Rewisca. And the higher you climb up, you want to use your weak opioids, your tramadol. You can use them in conjunction with the NSAIDs and your adjuvants. And the strong opioids, you would know your morphine and so on. All right. So whether it is neuropathic pain, inflammatory pain, or nociceptive pain, we have a wide array of products that can cover all of these. All right, thank you so much for having me.
You're welcome. So our last sponsor presentation of the night will be a video from Vitris. You can go ahead and play the video, please.
I am Odin Foster, medical representative here at Beatrice, and thank you for joining. Now, what patients desire most from pain management are reliable relief, fast action, and lasting results. With Celebrex, we can see how effective pain control can help patients to move with confidence, strength, and speed, getting back to their daily lives in as little as 22 minutes with sustained 24 hours relief. Celebrex is a potent analgesic and anti-inflammatory in both acute and chronic pain. In ankle sprain, patients treated with Celebrex experienced a significant reduction on weight bearing from baseline to day 3 compared to non-selective NSAIDs. In osteoarthritis, Celebrex showed similar efficacy with just a single 200 mg dose as ibuprofen at 800 mg 3 times daily. In terms of safety, Celebrex does not inhibit platelet aggregation involved in wound healing and interruption of ecchymosis that occurs with grade 2 ankle sprains. So therefore, if the patient needs to have surgery the same day, they can. Based on the post-hoc analysis of the precision study, unlike the non-selective NSAIDs shown, Celebrex showed a superior blood pressure safety profile with significantly lower incidence. Celebrex also showed a lower incidence of arterial hypertension over 12 weeks compared to non-selective NSAIDs and even compared to another COX-2. In fact, no meaningful change in systolic blood pressure was observed in the Celebrex group as seen in the graph. So what Celebrex offers is a balance between efficacy and safety. It offers rapid onset of action, significant pain relief in both acute and chronic pain, and prolonged pain relief. In terms of safety, Celebrex is the only FDA-approved COX-2 in the US. That's primarily because of its proven GI and cardiovascular safety versus numerous traditional NSAIDs. Celebrex also is not contraindicated in patients with hypertension. Just to remind you of the dosing, for acute pain, it's 400 milligrams loading dose and 200 12 hours after if necessary, and then 200 milligrams once or twice daily on subsequent days. For chronic pain, it's 200 milligrams once or twice daily, depending on patient response. So Celebrex has flexible dosing. While Celebrex speaks to inflammatory pain, when neuropathic pain enters the conversation, Lyrica finishes the story. Neuropathic pain is generally associated with comorbidities that can affect how the patient experiences pain. About 50% of patients with neuropathic pain experiences sleep disorders, and about 60% experiences anxiety. Now, in combination with the pain, the patients experience a reduced quality of life and functionality. Lyrica helps in the treatment of all the elements of the pain triad to improve the results of the patient. So less anxiety, less pain, less sleep disorders, more quality of life and functionality. And just to note, Lyrica actually has first-line indication for the treatment and management of generalized anxiety disorder. And Lyrica is associated with fast and significant reduction of pain at the very first week. 150 to 600 milligrams per day may be given in either 2 or 3 divided doses. The dose can be increased according to the patient's response and tolerability. Recommended start dose 75 milligrams twice daily, and after 3 to 7 days this may be increased to 150 milligrams 2 times daily. As it relates to migraine, consider triptans as first line when simple analgesics have previously failed. Relpax is a part of the stepwise approach for acute migraine treatment, as per the guidelines. Based on results from a meta-analysis of 74 clinical trials, Relpax had the highest probability of achieving pain-free response and headache response among oral triptans, as it demonstrated superior efficacy at 2 and 24 hours among these oral triptans. Relpax was the most effective oral medication in achieving pain freedom at 2 hours, even compared to some of its main competitors. Relpax is available in a 40 milligrams tablet. The maximum single dose is 80 milligrams. Relpax should be taken as early as possible after the onset of the migraine, and a second dose may be administered at least 2 hours after the first dose. No more than 80 milligrams should be given within a 24-hour period. That's the end of the presentation. Thanks for listening.
Thank you for that presentation. Our next presenter was to be Dr. Francine Gale, who was to present headaches in general practice. Unfortunately, she's medically unavailable at this time. So we'll have our next presenter with Dr. Karen Phillips. She will be presenting on neuropathic pain. Dr. Karen Phillips is a consultant physician, endocrinologist, and weight management specialist. She holds a MRCP in diabetes and endocrinology and completed a master's degree in obesity and weight management in 2022. She's a fellow of the Royal College of Physicians, Edinburgh. Dr. Phillips is a former head of Department of Medicine at the Kingston Public Hospital, an honorary consultant at the University Hospital of the West Indies, and an associate lecturer at the University of the West Indies. She is the director of Revamp Rehabilitation Center and Revamp Training Institute in Kingston, Jamaica. She is an avid reader and enjoys practicing yoga and meditation in her spare time. Thank you very much, Dr. Phillips, for your presentation. You can go ahead.
Thank you very much, Dr. French. So I would like to thank the CCFP for inviting me to do this very important presentation, which, we don't usually spend a lot of time as physicians talking about pain, and in particular neuropathic pain. So I'm going to go ahead and share my screen. All right. So in the next 30 minutes or so, I will be going through, the definition of neuropathic pain, just brief classification, looking at some of the causes, spending some time on clinical assessment, because as physicians, this is where we really have to focus our attention in order to know that we're treating what we should be treating. I'll round up with some few examples, and of course, treatment will be embedded within the presentation. So by definition, clearly, it's intuitive. Neuropathic pain is basically pain that is initiated or caused by a primary lesion in the nervous system. And there are two main types of neuropathic pain. We commonly focus more on peripheral causes in, private, general physician practice, but there are central causes that we may not encounter as readily, but we need to be aware of them, and peripheral causes. And the pathophysiology of pain is way above the scope of this presentation, but I thought that it would be important that we look a little bit at the physiology of pain perception, because ultimately we really need to understand what patients are experiencing when we are trying to treat their pain. And I know that as physicians, we generally, tend to just, somebody is having pain, just give them a painkiller. We don't really spend a lot of time thinking about, the physiology of the pain or some of the factors experienced by the patients that might be modulating the pain or causing, their own interpretation of the pain. And so generally when somebody receives an injury as outlined here, and this is like tissue damage caused by any kind of mechanical, chemical, or thermal stimulus, this really causes nociceptors to basically initiate an action potential. And so chemicals like inflammatory release of bradykinin, serotonin, prostaglandins. This kind of inflammatory soup is created, and this really lowers the threshold for activation. And so that's what we call transduction. Ultimately, we have transmission where the neural signal actually travels via first order neurons. And we can see here the A beta fiber, A delta fiber. And we know that the A delta will remember maybe responsible for fast, sharp pain, the C fiber for slow, dull pain. And basically, so this transmission goes via the peripheral nerve to the basically the dorsal horn of the spinal cord, right? And at this point, these neurons now cross to the opposite side and they ascend via the spinal thalamic tract, which you can see here, spinal thalamic tract, and go ultimately to the brain. And we're in the brain, mainly the thalamus, right? So the brain can modify, increase, or decrease the intensity of the pain signals through descending pathways. And it becomes very complicated here because there is now the whole aspect of endogenous opioids and endocannabinoids, which can inhibit or facilitate pain transmission. And there's a whole concept of the gate control theory, where there's non-painful stimulus. Like if you have pain and you rub an area, you buck your toe and you rub the area, and that almost helps to reduce the pain perception. So perception now becomes integrated right there. And ultimately, we move to the somatosensory area of the brain now where this really tells the body really how we are going to interpret this pain. So basically, that is, so this really refers to this somatosensory area, and a lot of the interpretation and the behavior of pain is basically, this is where it comes alive. So moving on to the common causes of neuropathic pain, we have both central and peripheral causes. And as I said before, we don't commonly treat the central causes, but we need to be aware of all the myelopathies, the compressive myelopathies, infective myelopathies, post-ischemic or post-radiation myelopathies. Post-stroke pain is a form of central neuropathy. And, even conditions like multiple sclerosis and Parkinson's, patients can have pain related to these from a central neuropathy, right? Compared to the common peripheral neuropathies, and most of us here, all of us here, we would have a lot of experience with treating painful diabetic neuropathy, post-herpetic neuralgia. Then there are the complex regional pain syndromes, mechanical neuropathies, again, HIV and idiopathic causes of sensory neuropathy. We would be familiar with, maybe not treated somebody with phantom limb, post-traumatic causes, trigeminal neuropathy, again, or neuralgia, we again may have some experience with. And then there's a whole range of cancer chemotherapy-induced neuropathies, which would have been mentioned before in Dr. Bandara's presentation. And if we try to narrow it down to make it a little bit more, neat, if you want to call it that, or easier to understand, we can group them according to the etiology, like the toxicity. So causes of neuropathic pain, which are because of toxic agents, such as chemotherapeutic agents or radiation therapy, which may cause abnormalities in protein processing, metabolic diseases, such as our diabetes. There's also uremia, which not mentioned here, but is also a cause. Trauma, again, causing regional pain syndromes, phantom limb, post-mastectomy. Again, these may cause abnormalities in afferent nerve signaling. Compressive causes such as carpal tunnel, which cause ischemia and some of the degeneration of neuroaxons. Autoimmune disorders, multiple sclerosis should really come under that as well, which can cause autoimmune antibodies to cellular proteins and or infections, right? So when we see a patient complaining of pain, we need to ask ourselves, what are the goals of our clinical assessment? What are we here to do for this patient? Are we here to just reflexively prescribe tramadol or, Baralgine or pregabalin? What are we really treating? And so it is very important that we stop and really ensure that what we're trying to do is to achieve a diagnosis of pain. And it may sound kind of weird for me to be saying a diagnosis of pain. The patient is saying, I'm having pain, but not everybody who says they're having pain they're necessarily having pain, one. And two, not all pain is the same. And so we definitely need to spend time to understand the etiology of the pain, the veracity of the pain, just understanding what they're really experiencing, their own interpretation of pain. And so we need to identify underlying causes of neuropathy to do that properly. If we're dealing with neuropathic pain, we need to identify any comorbid conditions, any psychosocial factors. We need to evaluate the functional status of the patient, their activity levels. What are we trying to achieve? To set goals, to help to develop a targeted treatment plan, and to determine when to refer to specialists or a multidisciplinary team, such as a pain clinic. And I say this because a lot of times we allow the buck to stop with us. So we prescribe some pregabalin 75 at night, or we prescribe gabapentin 300 milligrams once daily, and we forget about it. We really don't want the patient to be coming back each time and saying, I'm still having pain. But these patients come back and they're still having pain. And, I think maybe sometimes it makes us feel really ineffective as their care provider, not being able to solve this problem for them. But we also need to recognize that the buck does not stop with us. If we're treating somebody up and we think we're treating them, whether appropriately or not, for pain, and they're not getting the benefits of the treatment, then we need to consider that we may need to just move that patient on, right? And there are resources for that. So going back to medical school days in assessing a patient with pain, so any pain that a patient has, basically it's the same kind of questions that we think about and that we should really ask the patient about. So we always want to know about the onset and duration of the pain. Where is the pain? What's the distribution of the pain? Does the pain radiate? What is the quality of the pain? And this is very important for neuropathic pain. Even more than others, because it's really very telling when somebody comes to you with a lancinating type of pain, the intensity of the pain. What are the aggravating or relieving factors? Are there any? Are there any associated features or secondary signs and symptoms? Are there any associated factors? Are there any emotional issues, mood issues, any limitations in their functional activities? And ultimately looking towards treatment response, right? So we need to be aware of some of the terms that patients will come with when they're talking about neuropathic pain. And, we're frequently, bombarded with patients who will tell us they're having numbness or burning or tingling or, sharp, lancinating, electric-like, shooting or dull, deep. And we live in a very colorful society. So, some patients will just tell a low feeling when they're talking about a pain. So we have to really try to understand what the patient means by some of these terms and maybe try and substitute terms for them. Is it like this, or is it sharp? Is it like shooting? If we don't fully understand, but we must understand. And it's very important that we understand also that there are certain neuropathic pathologies or pains that patients will experience, like exaggerated symptoms. Like, say, for example, you may apply what is like a normal stimulus, something that does not usually evoke pain. Say to somebody with a diabetic neuropathy, you may touch the area with a soft piece of cotton, and the person may have an exaggerated response, and that is called allodynia. So that again can tell us a little bit about the kind of pain the person may be having, right? And this may be because of, you may apply a thermal stimulus, a mechanical stimulus, but not something that would normally evoke pain, and you get an exaggerated response. And at other times, you may actually get an exaggerated response to a normally painful stimulus. So you may be, say, for example, you're doing a monofilament test, or you're using some other sharp object, and when you try to apply the sensation, the patient will just maybe jump off the couch. So that's hyperalgesia. That is also very important to understand. And it's important to understand the difference between that and allodynia. So when we think about the pain treatment continuum, we have least invasive to most invasive. And of course, as it says, the continuum is not related to efficacy. So we have psychological, physical approaches. So those are non-pharmacological approaches. We have topical medications. We have systemic medications. we have interventional techniques. All of these may not be widely available, but we need to be aware of them. So the non-pharmacological options include things like biofeedback, relaxation therapy, maybe, not readily available, but physical and occupational therapy may be more available, cognitive and behavioral strategies through meditation or guided imagery, definitely available, acupuncture and TENS or transcutaneous electrical nerve stimulation, also very, very affordable and available. And it's very interesting to know that we're in an information age, and I have patients who come to me and tell me that, oh, I bought this on Amazon. So they're applying TENS for themselves and getting benefits. So, that is the time that we are living in. So these non-pharmacological options are available mostly and readily available mostly, and do offer some, relief to our patients with neuropathic pain. In terms of the pharmacological agents, we have a number of classes of agents with efficacy demonstrated in a lot of trials. So there are a number of randomized controlled trials that have been done looking at these agents. And, we've spoken about earlier, Dr. Reddy spoke about capsaicin. So we have our topical analgesics, such as the capsaicin and lidocaine patch. We'll talk about in a little bit. Anticonvulsants, as outlined here, antidepressants, opioids. And even though I'm not speaking particularly about opioids, I was told not to mention opioids today, still think that it is very important that we are aware of our opioids, because a number of us a lot of times patients come, they're not getting any benefit, will really just draw for a tramadol or a Tramaset, so tramadol plus paracetamol, without even thinking about it. But, opioids, yes. And so we do need to consider safety and tolerability when we're initiating treatment, and especially, depending on the agent that we're using. Now, there are some FDA-approved treatments for neuropathic pain. For example, we're aware of these. So I'm sure this is just repetition, but for those of us managing trigeminal neuralgias, we know the anticonvulsants like carbamazepine, very, very useful and FDA-approved. Good response to that. For peripheral diabetic neuropathy, duloxetine, not so available now anymore, but yes, pregabalin as well. For post-herpetic neuralgias, again, our anticonvulsants, gabapentin, also topical agents such as lidocaine patch, also very important. So just to remember these agents. And when we're using these agents, we need to recognize that really they will work at different levels. So if you're thinking about the peripheries and just peripheral sensitization, we can look at our lidocaine patch, so local anesthetics, topical analgesics, yes, anticonvulsants, tricads as well, and I guess there's the option of opioids at the dorsal horn level, where we're thinking more of central sensitization. Again, the tricads, the MMDA receptor antagonists, also anticonvulsants, and going further up, looking at modulation at the level of the brain and spinal cord, anticonvulsants and cyclic antidepressants, and of course, opioids. So it's just useful to kind of understand where the drug that you're going to use is likely to exhibit an effect. And if you remember just the physiology that I showed in an earlier slide in terms of, the transduction and transmission and modulation of pain, then you can have a better idea of how these drugs are actually helping your patients. Then we have our topical versus our transdermal delivery systems. And so for lidocaine, definitely this, as I said before, important in peripheral tissue activity. It is applied directly over the painful site. Really very good in terms of serum. There are insignificant serum levels of lidocaine, so we don't need to worry about that. And so systemic side effects are unlikely. So this is unlike the transdermal, like the fentanyl patch, which is not applied at the site of pain. Clearly, it's applied away from the painful site. There's systemic activity, so we need to monitor serum levels if available, and systemic side effects are likely. So just to bear those in mind. And the lidocaine patch, supplyable patch. Usually we use up to 3 patches once a day. Recently published data suggests 4 patches can be used up to 4 patches in 24 hours, usually 12 hours on, 12 hours off. And, also demonstrated to be efficacious in post-hepatic neuralgia. As I said before, drug interaction systemic side effects are unlikely. And the mechanical barrier decreases the allodynia I spoke about earlier. In terms of anticonvulsant drugs, we spoke about gabapentin pregabalin for post-hepatic neuralgia and also for diabetic neuropathy. We also have carbamazepine, phenytoin, lamotrigine, which can also be used in diabetic neuropathy. Not really encouraging, not all of these are FDA approved for diabetic neuropathy. HIV neuropathy and central post-stroke pain, lamotrigine can be useful. And for trigeminal neuralgia, as I said before, carbamazepine, very, very useful, and oxcarbazepine. So gabapentin, we use a lot of gabapentin. It's FDA approved for post-hepatic neuralgia, not for diabetic peripheral neuropathy. It works by antagonizing the alpha-2 beta subunit of voltage-dependent calcium channels at presynaptic sites. There's limited intestinal absorption, no significant drug interactions, half-life of 5 to 7 hours. No, the usual dose range is up to 3,600 milligrams distributed 3 times a day or delivered 3 times a day or 4 times a day. And we need to really look at the dose here because most of us, when using this drug, we're not using anything near this dose. And so we need to bear that in mind when our patients may not be having a desired response to the treatment. So pain relief can actually be rapid when it's working within the first or second week and grouped with the pregabalin here, and often accompanied by improvements in sleep and quality of life measures, which is very, very important. Note the side effects, which can range from ataxia to somnolence, dizziness, peripheral edema, weight gain. And both of them undergo renal excretion. So if somebody has renal impairment, we need to renally adjust the dose. This was mentioned by one of the sponsors tonight that the pregabalin does have anxiolytic effects in patients with generalized anxiety disorders, and so it is particularly useful for patients who may also be having pre-existing GAD. Carbamazepine, oxcarbazepine, these work through blocking of sodium channels and very useful for trigeminal neuralgia, lamotrigine and valproate. Basically have limited roles in neuropathic pain because there's some conflicting results from the randomized controlled trials. So looking at antidepressants, the depressants in neuropathic pain, when we think of our amitriptylines or tricyclics, these are commonly used. SNRIs, again, duloxetine is one of the FDA-approved medications for diabetic peripheral painful neuropathy, and they have multiple mechanisms of action. If somebody has pre-existing depression with their neuropathic pain, definitely they would be one of the first drugs that you would draw for, especially like venlafaxine. Persons, say for example, patients who have breast cancer with neuropathic pain, who maybe have menopausal symptoms, for whatever reason, maybe medications that they've been exposed to, maybe just they're going through menopause at that time. Very, very useful for the management of hot flashes and depression. And basically, these drugs also improve insomnia, anxiety, and depression. So we use a lot of amitriptyline. We don't always think about the commonly reported adverse effects, which are mostly anticholinergic effects. So the urinary retention, the tachycardia, this orthostatic hypotension, the dry mouth, blurred vision, cognitive changes, constipation. We don't commonly think about it, but we should really think about these side effects and talk to our patients about them. When we look at this, it's very, very interesting because we use a lot of amitriptyline, and it is one of the tricyclics with the most adverse effects. So we may need to just pay some attention to that. Desipramine are not readily available, nortriptyline, I suppose, can imipramine, but we do use a lot of amitriptyline. So we definitely need to pay some attention to the anticholinergic side effects that our patients may be experiencing. And again, these tricyclics are contraindicated with in patients with heart failure, cardiac conduction blocks, and epilepsy. said we're not really talking about opioids, but we really still should be aware of opioids. Because they can be effective in neuropathic pain. And we need to, however, understand that if we're going to use an opioid, and I say that because even we use a lot of tramadol, it's a weak opioid. And so we need to be aware that most of the adverse effects that these patients will encounter will include things like, severe constipation. So we have to think about how we're going to address this. And we need to definitely distinguish between dependence, tolerance, and addiction when we're thinking of these drugs. And just the difference. I wanted to point out particularly, even though we're not talking about opioids in this presentation, really, just to mention pseudo addiction and addiction, because pseudo addiction, we see this a lot of patients who exhibit behavior suggestive of addiction. And this is not really having to do with neuropathic pain, but we can think of our sickle cell patients, for example, who I'm sure all of us would have treated. And, sometimes they come to us and they're asking for medication, maybe asking for pethidine or asking for morphine, and sometimes we think they're addicted. And, it's really that their pain is undertreated. So we really have to be aware of that versus addiction, which is really psychological dependence. And really is a psychiatric disorder, which is characterized by continued compulsive use of the substance despite harm. And so that is very, very important for us to note. We should also know about tolerance, where patients may need more and more of a drug to maintain therapeutic effect, or it doesn't work over time, or physical dependence, where withdrawal symptoms will arise if the drug is discontinued or if the dose is reduced. Like ketamine, which is an N-methyl-D-aspartate antagonist, is not routinely used, and there isn't sufficient evidence to recommend this for any uncontrolled cancer-related pain. That's where it's more often will be used, and the use should be really reserved for treatment-resistant pain. Cannabinoids have become very popular, in recent times, but there are still concerns about abuse and addiction and also legal and regulatory issues. But it's very important to know that when we're thinking about treating neuropathic pain associated with nausea and decreased appetite, basically the effects of cannabinoids in helping with the emesis and also improving appetite can be really, really very useful and should be considered where available. Capsaicin was mentioned earlier, and we need to know that these really useful drug are very, very good results. They act via the transit receptor potential vanilloid 1 or TRPV1 receptor and may deplete substance P. And substance P, as was mentioned before, basically is one of those that release from the dorsal horn cells. And so reduction in substance P is going to be very, very useful in improving pain. And so definitely there has been recent recommendation for treatment of neuropathic pain, even in non-diabetic adults with capsaicin. Then there are interventional treatments which are not as readily available, but we should know about them. So there's nerve blockade, like sympathetic blocks. There's, there are neurolytic techniques such as, alcohol or phenol neurolysis. There's pulse reader frequency. There are stimulatory techniques such as peripheral nerve or spinal cord stimulation, and there are medication pumps. So, when we're looking at neuropathic pain conditions, apart from trigeminal neuralgia, the tricas and SNRIs or calcium channel agonists are usually first-line drugs that we would want to utilize. Not necessarily FDA recommended, but we usually pull for these drugs first. In patients with a focal peripheral neuropathy with allodynia, a lidocaine patch is a first-line drug and very useful. Remember that antidepressants may be first line in patients who have coexisting depression. And then tricas and calcium channel agonists again may be considered in patients with sleep disturbances. We spoke about pregabalin and its role in generalized anxiety disorder. So maybe first choice for patients who have coexisting anxiety. And we spoke about the opioids frequently co-prescribed in cancer neuropathic pain, because the cause of the pain in cancer neuropathic pain can be mixed. And really, the neuropathic pain really exists on its own in this kind of setting. So combination therapy is also important and may be considered in patients who don't have an adequate result with just one drug. There have been advances in treatments of neuropathic pain to include, we spoke about our lidocaine patch already, and we spoke about our transdermal measures such as our fentanyl, but botulinum toxin is also useful. The role of gabapentin, for example, in HIV-related neuropathy, diabetic neuropathy, we spoke about levetiracetam in neuropathic pain and migraine, and bupropion also in neuropathic pain, not readily available though, but just to understand what is out there. I just wanted to spend the last maybe 10 minutes talking about diabetic neuropathy and post-hepatic neuralgia because we do see a lot of diabetic neuropathy, right? And there are different types of diabetic neuropathy. We're focusing on the symmetric polyneuropathy today. And I came across this, thought it was useful because when we see our patients with what we presume is diabetic neuropathic pain, based on our clinical assessment, we need to think about it in terms of large fiber neuropathy, small fiber neuropathy, especially to distinguish between these two is very important. And then, of course, our proximal motor neuropathies, we need to be aware of these, our acute mononeuropathies, and our trapping neuropathies. Now, very, very important to know that for all of these neuropathies, we're going to have some sensory loss, right? For large fiber neuropathies, loss to soft touch, vibration. To small fiber neuropathy, that's when you get the allodynia, where you apply just a normal stimulus and the patient is jumping off the couch. Thermal loss as well. In terms of reflexes, so our ankle reflex, we usually spend a lot of time looking at that. And so for all of these, except for the acute mononeuropathies, you will have some decrease in our tendon reflexes, right? And motor deficit, the only one which does not really result in a motor deficit is our small fiber neuropathy. So the distal symmetric polyneuropathy definitely is our most common form of diabetic neuropathy. It's chronic nerve length dependent and it's a sensory motor neuropathy, polyneuropathy. At least a third of patients with type 1 or type 2 diabetes will have this, and up to a quarter of patients with impaired glucose tolerance of diabetes. So this is very, 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 very important to know because people, patients themselves, oh, they have borderline diabetes, they don't take it very seriously. We as physicians sometimes may, write stuff, oh, yes, you're pre-diabetic, but not understanding that, number of these patients with pre-diabetes do have diabetic complications. And the risk factors, of course, include hypoglycemia, duration of diabetes, smoking, high blood pressure, weight, increased lipids, and the differential diagnosis, as would have been alluded to before, other metabolic causes such as thyroid disease, renal disease, systemic vasculitis, and non-systemic vasculitis. These are also important. Infections like HIV, hepatitis, inflammatory causes like chronic inflammatory demyelinating polyneuropathy, and nutritional causes such as vitamin B12 deficiency. Very, very important. And just to remind us that a lot of our patients will be on metformin for a long period of time. And remember that sometimes over time can result in some of, the B12 deficiency and the issues related to that. So in terms of the pathophysiology of diabetic polyneuropathy, definitely hypoglycemia and hyperlipidemia play a very, very important role to protein oxidation, lipid oxidation, resulting in inflammatory signals and ultimately reactive oxygen species, which will cause DNA damage, endothelial reticulum stress, mitochondrial dysfunction, and cellular injury and irreversible damage. So when our patients come to us and they say, Doc, can this be reversed? And we tell them, not really. This is what it means. Can be reversed, definitely can be improved with glycemic control and just, managing your diabetes and your comorbidities better. But definitely there's a permanent sequelae here. So our patients come to us, and as we said before, for diabetic symmetric polyneuropathy, the symptoms are predominantly sensory. For large fiber neuropathies, there can be some motor impairment, especially later on, but definitely predominantly sensory. And we think of these symptoms in terms of positive symptoms and negative symptoms. So our patients may come saying, oh, I'm having burning, I can't sleep at night. tingling and burning and stabbing in the feet, and I can't. So those are your positive symptoms versus those who come and they don't complain of any pain. They're not having any pain. They say, no, they don't have any pain. They have a little bit of numbness, but no pain. You know, they feel a little weak in the limbs, but no pain. So remember, as I said before, the motor symptoms are less common, occur late in the disease process, and usually for the large fiber neuropathies. Decreased sensation is not a good thing. We all know this is a predisposition to painless foot ulcers and subsequent amputations. And so we must be aware of the complications of this ulcer and gangrene in up to 15 to 25% of patients, resulting in our amputations. Imbalance and unsteadiness in gait. So these patients have fall risks. You know, they have lacerations, fractures, traumatic brain injuries, you know, foot ulceration, and Charcot neuroarthropathy are leg complications. And these leg complications are definitely tied to increased mortality. So it's an example of a Charcot foot, you know, so this is a diabetic patient with Charcot arthropathy, and here you can see collapse of the arch of the midfoot. This is replaced by this bony prominence here, and there are several factors which contribute to this, including small muscle wasting, maldistribution of weight, and decreased sensation. So in assessing our patients then with symmetric diabetic polyneuropathy, a thorough history is definitely important. Definitely we need to ask about the drugs. We need to ask about chemical exposure, inherited neuropathies. You know, so we say drugs, metformin, you know, other drugs, chemical exposure, inherited neuropathies, other comorbidities, you know, kidney disease, etc. You know, we spoke about all of this before. And then remember, we're thinking about a small fiber and a large fiber. For a small fiber, we want to do check for temperature, pinprick sensation. For large fiber, vibration sensation is one of the earliest to go. So very useful to have that 128 hertz tuning fork and to do the 10-gram monofilament testing annually. So atypical features such as predominant motor neuropathy, or patients who have asymmetric symptoms or rapid onset of symptoms, these patients, we definitely need to do some electrophysiological testing or send them on to neurology, right? So that would not be consistent with what we would expect for a diabetic polyneuropathy, peripheral neuropathy with predominant motor issues and rapid onset of symptoms. Again, just to compare the two in terms of large fiber and small fiber, the patient who comes with, you know, balance issues and not feeling so well, and so numbness, I mean by that, versus those who come with, a lot of pain, the positive symptoms. So there's more, they're more prone to the nociceptive stimulus. So we talk about the numbness, the tingling, the poor balance for the large fiber patients, and for the small fiber patients, those who are affected, they're small fibers, the positive symptoms as we mentioned before. And as in terms of our examination, we all should be checking our ankle reflexes, have that 128 hertz tuning fork, have a 10-gram monofilament, and we can easily check for proprioception. Don't need anything to do that. So all of these will be impaired for large myelinated nerve fibers. For the small myelinated nerve fibers, cold and hot discrimination important because this is always going to be reduced or absent, and the pinprick sensation is going to be reduced or absent. So the key components of the diabetic foot exam, we must do inspection. Inspection, we know for any form of examination is of paramount importance. So we need to look at the skin, the color of the skin, the thickness of the skin. Is it dry? Is it cracking? Any sweating? Is there an infection? Are we looking between the toes? Are we looking around the nails? Are there any ulcerations, any calluses, any blistering, any deformities, claw toes? Charcot's joint, which I just showed. And in our neurological assessment, the 10-gram monofilament plus one of the following four. So we all should have a 128 hertz tuning fork to check for vibration, pinprick sensation, I said before, ankle reflexes, and vibration perception testing. Not so readily available, but very, very, very useful and sensitive in picking up early vibration loss. And then, of course, vascular assessment, looking at ankle brachial index and the foot pulses. So this is where we should be checking with our 10-gram monofilament. So each of these 12 sites really represent the most common sites for foot ulceration. So failure to detect cutaneous pressure at any site suggests that this area is at high risk for ulcer formation. So these are the areas that we need to be tested. And now finally for post-hepatic neuralgia, we're talking about pain in a dermatomal distribution that is sustained for at least 90 days, after the rash, right? So basically the pain is described as burning, shooting, tingling, it's sharp, and there may be allodynia. Remember allodynia, so kind of exaggerated response to a normal stimulus, or hyperalgesia, again, to a painful stimulus, exaggerated response. So here we have our patient with acute herpes zoster, so dermatomal distribution, and we're used to our vesicular rash. And then when the rash is fading or disappearing, the pain persists and can go for over 4 months. So this is now post-herpetic neuralgia. And of course, the pathophysiology of herpes zoster, we should always remember that after the primary varicella zoster infection, latent infection is established in the sensory cranial nerves and the spinal dorsal root ganglia. And we must remember that the trigeminal and thoracic ganglia are the most common neuronal sites involved. So most of the times, these are patients come to us and the eruption is in the trigeminal distribution or the thoracic dermatomal distribution. So this is where we tend to see eruptions. Thought this was very important because, of course, we know we generally see post-hepatic neuralgia or varicella zoster in older age groups. And of course, we remember that this starts with varicella exposure at a young age. We may have silent reactivation early on as well. And then there is this, goes away. Basically, it's latent now, and then it reappears in later life as, zoster, herpes zoster. But note that with the zoster vaccination, there's definitely an improvement or reduction in the occurrence of herpes zoster or post-herpetic neuralgia as a result of that. And the treatment is pharmacological or non-pharmacological. So first-line treatment, pharmacological, would be your tricyclics, as was mentioned before, anticonvulsants or topical lidocaine. Second or third line, NSAIDs, steroids, opioids, or combination. Non-pharmacological physiotherapy, psychology, we spoke about meditation, cognitive therapy, nerve block stimulation. And of course, we need to spend time looking at preventing chronic pain by more aggressive treatment of acute pain and by avoiding infection with varicella zoster in the first place. So prompt treatment of herpes zoster, like with oral antiviral agents, is very, very, very important. As I said before, the herpes zoster vaccine, again, very, very important. We know that with this vaccine, compared to placebo, there's a decrease in the incidence of post-hepatic neuralgia versus placebo by approximately 2/3. So just to summarize what we've been talking about today, chronic neuropathic pain is a disease. It is not a symptom. So we need to get to the bottom of it. We need to understand it, and we need to understand what the person is feeling and perceiving as pain. Rational polypharmacy is often necessary, so we need to combine peripheral and central nervous system agents a lot of times to enhance pain relief. Remember our treatment goals, which are balancing efficacy, safety, and tolerability. Remember to reduce baseline pain and pain exacerbations, improving function and quality of life, also very, very important. And there are new agents and new uses for existing agents, which offer additional treatment options. And last but not least, just to remember that when we're doing what we think we're doing for the patients, when what we're doing for the patient is not enough, the buck doesn't stop with us. We can always move the patient on, to pain specialists or a pain clinic. There's one at KPH, helping a lot of these persons who are, suffering from pain. Thank you. That's the end of the presentation.
Thank you very much, Dr. Felix, for an excellent presentation, especially going through diabetic neuropathy, which many oversee in primary care.
Right.
I will now
I
check
should
to
share
see.
my two questions. Let me just go back and share it. So
Okay.
I am not seeing the share button. Yeah, okay. So I have two questions. All right, I have two questions. No, I'm on the wrong thing, sorry. No, I'm not. Just 1 second. I'm not sure why I'm not seeing my questions.
We are seeing them.
You see them?
Yes. Would you like me to read it or?
Yes, read it for me, please, because I'm not seeing.
Okay, so case one is a 68-year-old male with a 15-year history of type 2 diabetes and hypertension. He presents with worsening bilateral pain and tingling in his feet, especially at night. He's maintained on metformin 1 gram BD and diamicron 60 milligrams OD. It went away, Dr. Phillips.
Oh, it went away? Oh, dear.
Yes.
Is it back?
Yes. So
Mhm.
he's maintained on metformin 1 gram BD, diamicron 60 milligrams OD, and enalapril 10 milligrams BD. Examination reveals absent ankle reflexes and decreased vibration sense peripherally. His investigations remarkable for HbA1c of 14.9%, total cholesterol of 6 millimoles per liter, LDL of 4 millimoles per liter, and estimated GFR greater than 60. Can you press the next slide, Dr. Phillips?
I'm not seeing.
Slide 3.
Are you seeing it?
We're just seeing the case one that I read, and then on the other side we're seeing 2, 3, 4.
I'm not sure what's happening to this. But I'm gonna stop the sharing and see if I can find the question myself.
Okay.
All right.
In the meantime, if anybody has any questions, please post them in the Q&A.
All
Thank
right, so
you.
I'm gonna read. Are you hearing me?
Yes, we are.
I'm gonna read the answers from that case. So A, he likely has a large fiber neuropathy and would benefit from improvement in his glycemic control. B, he likely has a large fiber neuropathy and would benefit from gabapentin 300 milligrams OD. C, he likely has a small fiber neuropathy and would benefit from improvement in his glycemic control. D, he likely has a small fiber neuropathy and would benefit from gabapentin 300 milligrams OD. What is the correct answer? Any takers? Nobody type anything in the chat? A, B, C, or D? All right, so the answer is A, because based on the fact that his vibration center was impaired, as we said before, that's more large fiber issue than small fiber. Small fiber is more temperature and pinprick. So he likely has a large fiber neuropathy. And I wanted to highlight in that question that basically, though we use a lot of gabapentin, we see a lot of persons using gabapentin 300 milligrams once daily. That is not going to work. So we need to be actually giving at least 3 times a day, 300 to start. But most of these patients, if you look at the studies, the doses that they really use are up to 3,600 or more for the day. So that dose, that would be a case of us treating the patient, but a suboptimal treatment. And the patient will coming back with the pain and the pain and the pain, not getting any joy from the treatment. And we get a little bit frustrated because what we're doing is not helping, but it's really a dose issue. And just to remember though, that a lot of patients will come and they want to know if it can be reversed. The pain that they're having, it's very disturbing, it's affecting their quality of life, but it cannot be reversed. But with good glycemic control, it can improve, but it won't totally go away. So definitely, good glycemic control will definitely help. It won't cause it to disappear or, to resolve totally, but definitely with some improvements. The next question I wanted was a 46-year-old female with a history of C13 presenting to her private practitioner with a 2-week history of a rash to the right side of the abdomen with associated blisters. So clearly she has herpes zoster. The rash has improved with home remedies, but over the last few days, she has experienced severe pain at the site of the rash, even though the rash is improving. An examination reveals a mild erythematous vesicular rash in T11, T12 dermatomes. And the question here is, which of the following should be considered first line in treating her pain? And we want to choose the best option. So we have gabapentin, duloxetine, pregabalin, A. B, we have tramadol, pregabalin, amitriptyline. C, we have capsaicin cream, amitriptyline, tramadol. D, we have lidocaine patch, physical therapy, pregabalin. So, of course, the answer is A, because there are 2 FDA-approved drugs here, duloxetine, pregabalin. Even though we're not seeing duloxetine anymore, and gabapentin do not FDA-approved, at the correct dose can be very useful for treatment of painful diabetic neuropathy. So that is it from me. Any questions?
Thank you very much, Dr. Phillips. There are no questions in the Q&A at this time.
Oh, there are persons who are answering. Good. Yes.
Right. So in the other chat, there were people that were answering the questions that you asked.
Yeah. Okay.
If there are no further questions, I'd like to thank everybody for turning out to part 1 of a 2-part series of our pain management webinar. I now invite Dr. Kian Bukal to give the vote of thanks.
All right, good evening, everyone. Thank you so much for joining us on part 1 of our pain management series. We thank, first of all, the Lord for taking us through this day. And we thank you, our guests, for, participating and for your attention throughout the course. We thank our speakers, our excellent speakers. We thank Dr. Bandara Kaur talking to us about palliative care. And my takeaway from that is that the quality of life affects or improves the quantity of life. And just The fact that we have to treat the whole person, not just the physical, but we attend to the emotional and the spiritual. Thank you very much, Dr. Bandar and Dr. Philip. Thank you so much for teaching us about neuropathic pain, going through the pathophysiology of pain, as well as what we could use to treat the various different types or different causes of neuropathic pain. We also thank our sponsors. We thank Indus Life Sciences, talking to us about Capsitop, amongst other things. We thank Servicare for their Kirka products, the Naclofen Duo. And we thank, of course, Viatrist in their talk about Celebrex and Relpax and Lyrical. We thank, of course, our other panelists, Dr. Seni and Anuju, and we thank Sam, our technical person, for taking us through the night. You do have a good night, and please join us again on the 22nd of February for part 2.
Thank you,
Thank you.
everyone. Good night.
Good night. Good night. Thanks so much for joining, everyone. See you for part 2. Stay safe. Have a wonderful evening.